Head and neck infections are always 100% of the time on step 2. Otitis, sinusitis, pharyngitis, and the flu.
Otitis media, answering the question, what's the most likely diagnosis? You should expect to see redness, immobility, bulging, and decreased light reflex of that tympanic membrane. Oh, there it is. Pain and decreased hearing and fever. Which of these is the most sensitive physical finding is unquestionably immobility. If you see a freely mobile tympanic membrane, it's not otitis media.
So here it is. Let's take what we just said as a fact biopsy. Let's take what we said as a list of info and teach you how to think like a person who's writing questions. See, the last is a list of stuff to remember, but this is how to think like preparing for step 2. Take the same info and simply say, which is the most sensitive physical finding for otitis media? Isn't it the same? Yeah, but it feels differently, doesn't it? Yeah, it does. The most sensitive physical finding for otitis media is immobility. You see, if you've got a freely mobile tympanic membrane, you just don't have otitis media. You could have otitis media without redness. Now, redness goes with otitis media, but you don't have to have it to have otitis media. Now, bulging goes with otitis media, yeah, but you don't have to be bulging to have otitis media. Well, decreased light reflex and decreased hearing go with otitis media, but you don't have to have them. They're less sensitive. But if you've got a mobile tympanic membrane, waka waka waka, move move move, it ain't otitis media. Insufflation, blow the air in. There is no radiologic test to diagnose otitis media, therefore, it's based on physical findings. Now, what if the question says, well, what is the most accurate diagnostic test? Here's where you must distinguish between the question, what would you do, and what is the most accurate. A person comes with a red, bulging, immobile tympanic membrane. What would you do next? Well, the answer is start therapy with amoxicillin and decongestant. Start therapy. The same question says, what is the most accurate? Ooh, that's different. Tympanocentesis. I want to tell you why students get this wrong. Because they can't read the question correctly. The question says, what would you do? And they hear most accurate. The question says, what's the most accurate? And they hear, what would you do? What's the most accurate? I didn't say I'd do it. Tympanocentesis. Needle in the ear, take a sample of fluid for culture. It is the most accurate test, and you choose tympanocentesis if there's multiple recurrences, and there's no response to multiple antibiotics, and it keeps coming back and coming back, or it's not getting better, not getting better, not getting better. And remember, the radiologic tests for otitis are always a wrong answer. The best initial therapy hasn't changed in 50 years. Amoxicillin was the best initial therapy. It still is. And that's frankly because most of them would get better by themselves. They don't need any treatment. A lot of them are viruses. So most would get better with chocolate. You get a placebo. The placebo arm gets better 60% of the time. What you're doing with the amoxicillin is pick up an extra 20 or 30% to go from 60 to 80 to 60 to 90% resolution. If there's no response to amoxicillin or it recurs, the answer is amoxicillin, clavulanic acid, azithromycin, clarithromycin, cefuroxime, loricarbef. Cefuroxime, loricarbef, what generation? Second. They're oral second generation cephalosporins. What? Levofloxacin, ganifloxacin, moxifloxacin. Oh, but what if they put all these in the same question? Contraindication. Remember, if you have these in the same question, there's a contraindication there. Remember, Levogide, Moxie, no quinolones in kids. Quinolones are relatively contraindicated in children, causes bone growth abnormalities, bad to the bone. Quinolones, bad to the bone.
A 34-year-old woman has facial pain, discolored nasal discharge, a bad taste in her mouth, fever, and face tenderness. What's the most accurate diagnostic test for this person? The answer is a sinus biopsy or aspirate. This really comes down to how do you know what organism is inside those sinuses? Well, you can't know what organism is inside the sinuses by doing a CT or X-ray. CTs, X-rays, MRIs, no radiologic test is able to prove what organism is inside an organ. You just can't tell. You can't stain a CT. You can't culture an MRI. The problem with culturing discharge is you don't know if it correlates to what's actually inside the sinuses. It's most likely colonization. You really can't base treatment on that. Transillumination is okay for telling if there's pus inside the sinuses, but in the same way, culture of the discharge is always the wrong answer for sinusitis because you'll be growing something that's not what's really inside the sinuses. Transillumination doesn't grow anything at all, it just tells you that there's mucus. So it doesn't provide precise microbiologic diagnosis. Now, the only time that this procedure, sinus biopsy or aspirate, would be necessary is if a patient had recurrences or simply didn't improve with therapy, and you really had to know what organism was in there. Only if there's no response or recurrences.
Culture of that nasal discharge is always wrong answer for sinusitis. Use an aspirate, a biopsy, or an aspirate, and it's only if the infection recurs frequently or there's no response. It's just like the tympanocentesis. What is the most accurate does not mean you do it. You only do it if it recurs or there's no response. 34-year-old woman with facial pain, discolored nasal discharge, bad taste in her mouth, fever. She has facial tenderness. What's the next step? Action management. The answer is amoxicillin decongestant. Go straight to therapy. Linezolid would not cover this because it would only cover pneumococcus. It wouldn't cover the Haemophilus. Hey, how can you have Haemophilus in there? After all, I thought there was Haemophilus vaccine. Ooh, yeah, but the Haemophilus that causes sinusitis and otitis is non-typable Haemophilus. Sinusitis and otitis is non-typable Haemophilus. So you can get the old non-typable, but linezolid's great for gram negatives, resistant gram positives, great for gram resistant gram positives, but just won't cover Haemophilus. CT scan and X-ray are simply not good enough because the diagnosis is clear. You don't need the diagnostic test when it's this clear. And erythromycin is just not good enough for strep pneumonia. Just not good enough. Pharyngitis is pain on swallowing. It has enlarged lymph nodes in the neck. There's an exudate in the pharynx. Look at that nasty stuff in the back there. But it's a great picture, though. It's a great picture. It's exactly right. There's a fever and no cough or hoarseness. Now, when you see these criteria, of which there are 5, basically pain, nodes, exudate, fever, and the absence of cough or hoarseness, you have an over 90% chance that this is streptococcal pharyngitis. They really do. And so that's why this doesn't quite eliminate the need for culture. But if you have these things, it's enough to say treat empirically. Now, the reason that there's no cough or hoarseness, that cough means a bronchitis in the lungs, and hoarseness is a pharyngitis. No, hoarseness is a laryngitis. Hoarseness is laryngitis, not pharyngitis. The pharynx is above the larynx, and hoarseness is virus on cords. The best initial test is a rapid strep test. Now, the rapid strep test is an office or clinic-based test that finds group A beta hemolytic strep in minutes. And this is so you can know that if the rapid strep test is positive, that the person needs a full course of treatment for the streptococcal pharyngitis. Now, in adults, a negative rapid strep test is sufficient. The pediatric section may tell you something different. The pediatric section, we would treat until the culture is negative. But in an adult in which group A beta hemolytic strep is unusual, a negative test excludes disease and antibiotics are not needed. A positive rapid strep test means you got it. That's positive for pharyngeal culture. It's the same thing. It's good enough. Its specificity is excellent. Remember that ultimately the reason we're treating is because we want to prevent rheumatic fever. We want to prevent rheumatic fever and post-streptococcal glomerulonephritis. That's the main reason we're treating. Vesicles and ulcers are herpes simplex virus, herpangina, because it hurts. Herpes that hurts. Herpes that hurts me. Membranous exudates are diphtheria, Vincent's angina, Epstein-Barr. So there's a lot of things that cause infections and cause exudates sometimes, but they're not needing to be treated for a group A strep. And that's why less than 20% of pharyngitis is group A strep. Did you know that? Most people don't because you're focused on the one that you have to treat to prevent rheumatic fever and prevent glomerulonephritis. nephritis. The treatment of pharyngitis hasn't changed in 60 years. Penicillin or amoxicillin was the best initial therapy in the 1940s and 50s, and it is now. If you're penicillin allergic, we follow the algorithm that we thought of before when we talked about penicillins in general. If it's only a rash, please feel safe to use cephalexin. Now, I know that there's going to start to be times like this where I have such familiarity with the wrong answers that I can tell that some of you are probably cringing. You're saying, my God, that's so different than what my resident, my attending said. I hate to tell you this, but they're wrong. There's only a tiny amount of cross reaction. And if there's an anaphylactic reaction, clindamycin or macrolides are the right answer. And this hasn't changed for a long, long time. Streptococcal pharyngitis is just treated to prevent the rheumatic fever. And if there's a rash, if it's just a rash, use the cephalosporin. That's cool. You can take everything that we're doing here and use it to treat patients. You cannot take what you see on clinical rotations to always answer questions. Here, you could take arthralgias, myalgias, a cough, a fever, headache, sore throat, nausea, vomiting, especially in children, for viral syndromes, and say, yeah, that's the flu. That's it. Let's get the treatment. Now, the most appropriate next step in management depends on the time course from the presentation. If it is within 48 hours and you want to be certain, you do a nasopharyngeal swab or wash, and it's like a rapid antigen detection method. It's called a point of care test. Great term, point of care, meaning at the point you're rendering care, instantly, on the spot, in the office, in the room. Isn't that amazing? You take a little swabby swab and you get your diagnosis on the spot, and you can give treatment. Within 48 hours, treat with oseltamivir and zanamivir. They are neuraminidase inhibitors, and they shorten the duration of symptoms, and they treat both influenza A and B. Despite the fact that this is very clear and the therapy is non-complicated, and despite the fact that it will make you feel better, this question is answered incorrectly by the majority of students. 60 to 80% are wrong. That is probably because the American physician, medical student, and resident, when they're sick, go to work. They're rather on the tough guy side, the tough lady side. So we tend to not treat ourselves. And we project that onto our Step 2 exam, and we get the question wrong. If it's above 48 hours of symptoms, then it's symptomatic therapy. But again, no matter what you think or what you've seen, if it's less than 48 hours, give them the neuraminidase inhibitor. Above 48 hours, symptomatic therapy, ibuprofen, naproxen, sulindac, meloxicam, rest, antipyretics with acetaminophen, hydration, water yourself. And the neuraminidase inhibitors are symptomatic. They simply make you feel better. And oseltamivir and zanamivir don't treat complications of influenza, such as the pneumonia. They simply make you feel better faster.